this morning, featuring three tremendous women leaders in California who are people who have been doing the hard work during this pandemic, really working to meet the needs of our communities. It's been nearly a year, which is kind of amazing to think about, since Governor Newsom issued the first statewide stay-home order in response to the community transmission of COVID-19 throughout the state. And since that time, there have been nearly 3.5 million recorded cases in California and over 43,000 deaths. 2/3 of the cases and the deaths are in our communities, are in communities of color. And this is continuing today. Given what we know about structural racism, this unfortunately comes as no surprise. And yet, our communities are resilient. And there's so much that we can learn about what our communities have been able to do during this time to really show us the way to a more equitable state. So I want to introduce our phenomenal speakers, and what I'm going to do is I'm going to read just a snippet of each of their bios, and then I'm going to ask each of them as I finish their bio to say hello to make sure that we have them and we have their sound here. So this, you'll all get to participate in our tech check. So first, I want to introduce Dr. Noha Abalata. She's the Chief Executive Officer of the Roots Community Health Center, a key CPEN partner. She has devoted her career to eliminating health disparities and improving the health of marginalized communities. Through Roots, which Dr. Noha founded in East Oakland, she has pioneered the delivery of culturally responsive whole health and championed the integration of the physical and behavioral health care, workforce enterprises, health navigation, and mobile medical services, which address the needs of the over 10,000 members of Roots. She also serves on the Board of Governors for the Alameda Alliance for Health and is the immediate past chair of the Alameda Health System Board of Trustees. So Dr. Noha, do we have you with us? Okay, so this is why we do this. So our tech people will keep working on that, and we will go to our next speaker, Dr. Elizabeth Hernandez, who is the Assistant Director for the County of San Diego Public Health Services. She oversees the public health services operations, which includes tuberculosis control, refugee health, preparedness and response, maternal, child, and family health services, California Children's Services, HIV, AIDS, STD, and hepatitis, as well as the epidemiology and immunization branch. I have no idea how one person does all of that, but she does. She provides the direction and support to these public health services branches in the areas of budget development, fiscal processes and accountability, contracting, quality management, and the list goes on. So welcome, Dr. Hernandez. Do we have you with us?
Yes, good morning, and thank you so much for having me. Thank you.
Fabulous. And then last but not least, we have Diana Tellefson-Torres. She has been the Executive Director of the UFW Foundation since 2006 and a National Vice President of the United Farm Workers of America since 2008. The UFW Foundation won overtime pay after 8 hours a day for California farm workers in 2016 and is working to expand these protections nationwide. The UFW Foundation, under Deanna's leadership, has mobilized farm workers and their organizations across the country to advocate for immigration reform, pesticide protections, heat standards, hazard pay, and other worker protections. They've taken hundreds of farm workers to Washington, D.C. to lobby on their own behalf. The UFW Foundation is the largest federally accredited provider of immigration legal services in rural California. Deanna, do we have you with us?
I'm here. Good morning. Thank you for having me.
Fabulous. Welcome. Welcome, welcome. And I'm going to double check. Do we have Dr. Noha with us?
Yes, I was able to turn on my video and unmute. So good morning. Thank you so much for having me.
Fabulous. So thank you three so much for being with us. And I'm going to just dive in here because we really want to hear from you. So Dr. Noha, the first question is for you, which is, we've, I think, heard a lot of the statistics about disparities and the really tragic statistics about deaths in our communities. But sometimes the community story really is missing from that picture. And you at Roots, you've been doing regular community updates to share the story of what's happening in East Oakland. So can you take us into kind of a version of your community update and tell us about the community that you serve and what you've experienced over the past year?
Sure, thank you. Yes, so we are located in East Oakland, which is the area of our county that has been hit the hardest by COVID, which is something that, of course, we sort of sadly predicted before, at the early kind of stages of the pandemic, simply because this is a neighborhood that is historically has been redlined in the past and sort of has the same disparities with a number of different health indicators. And what we saw was that, as with this pandemic, it really has a different impact depending on where you are. And it just looks very different depending on where you are. And we were feeling like there wasn't enough sort of targeted messaging towards a specific community. So we started what we call the People's Health Briefing back in July. And it's been going every Tuesday morning. It's about 15 minutes, and it's a basic update that is really focused on Oakland and East Oakland in particular. And we go over the data, what we're seeing with cases and with deaths. And then we go into the questions and concerns and really reporting back on the data that we are gathering from our testing site. And so what we were seeing is that, as we call people who test positive and as we do contact tracing and we learn specifically what's going on in our communities, like why it's spreading rapidly in some neighborhoods, then we're able to feedback that information. And so we've been able to give detailed information about what sectors people work in, where we're seeing a lot of outbreaks or disproportionately seeing cases. And we've just been able to basically share out what it is that we're learning on the ground and respond to people's, the concerns they have, but also some of the myths that we know have really been also plaguing us during this time with sort of this infodemic, and really trying to just give the facts. And particularly now with the vaccine, I think it's been really important for us to just be transparent. This is what we know. This is what we don't know. This is the choice that we have in front of us. And this is a situation that we're in right here within our community and within our neighborhoods, and able to even share, some of what we're seeing in terms of the disparities. And so I think it's been a really important tool, because information is changing so quickly. Sometimes it feels like by the hour. And so having a dynamic way to be able to report back has been something really important that we've got a lot of great feedback from our community about.
Thank you, Dr. Noha. And can you describe, sort of what you've seen over the past year in the community, and how does it maybe differ from what the state is reporting at large?
Yeah, well, I think it's sort of really shown how important it is to be hyper local and have a very intimate understanding of what is going on right in your community, because one size does not fit all. And particularly with this pandemic, where decisions are being made based on averages. And so when we say, oh, we can go to this tier or we can reopen this or that, it's based on averages. And those averages look vastly different from what we're seeing in our community. So in the zip code where Roots Community Health Center is located and a couple of adjacent zip codes, our case rates have been triple the county, double to triple the county the entire time. So if you just used our neighborhoods, we wouldn't be moving in any tiers. And so I think that it's important to share that. And I think, when people talk about equity and not wanting to stigmatize a neighborhood because of high case rates, I do understand all of that. At the same time, we deserve to know what's going on. And we deserve to understand that just because the whole county is moving into another tier doesn't mean that where you are in particular has met those same milestones or those same benchmarks. And so what we've seen basically is that the transmission rates are hyper-local, the case rates are hyper-local, and the decisions are statewide or countywide. And so I think it's really important, I think, again, just arming people with that information, because perhaps some of the activities that might be safe in one part of the county the virus is just circulating at too high of a rate in other parts of the county, and we deserve to know that and not be sort of given this false sense of security based on averages.
Yeah, thank you for that. I think that's really important, and it sort of leads me to the next question for Deanna, which is, you do a lot of work in the Central Valley and in other rural regions of the state where we have many farm workers who are working to feed all of us. And the Central Valley has been one of the hardest hit regions of the state. It was the first place where our intensive care unit capacity hit zero, right? And yet we continue to overlook that region when it comes to resources. We just saw some figures about where vaccines have been allocated, right? And it's not the Central Valley. So what can you share with us about the experience of the last year in the Central Valley region and with the farm workers who are part of your organization?
Thank you, Karen. Well, even before COVID-19 struck, farm workers were already among the most vulnerable employees in America. So, as we went down into a lockdown, it was very clear that farm workers were going to continue to work, that they did not have the luxury to shelter in place and be at home. And so a lot of the multiple effects that we're seeing from the pandemic, we knew farm workers were overwhelmingly going to be impacted. So, farm workers are very mobile, and so they have not been able to escape the perils of the virus. So they're regularly living in overcrowded, sometimes substandard or unsanitary conditions, commonly in multi-family households. They're carpooling to work, packed in vehicles or in vans out of necessity. Many of the farm workers in this state are making low wages. They're very poorly paid. And so workers are frequently driving with others who they do not live with. And in rural areas, we also know that there isn't as much access to public transportation. And workers are frequently toiling shoulder to shoulder in fields or in packing houses. It's often very challenging to social distance in certain workplaces. And the measures that are taken into account at the workplaces are often lacking, I should say. From the beginning of the pandemic, farm workers were telling us that they were not receiving masks, that they weren't receiving the appropriate PPE, that soap sometimes wasn't as accessible in the bathrooms that they were utilizing. And so those concerns were really being lifted from the beginning. And we continue to hear concerns that masks aren't being provided. What we're hearing from farm workers on the ground who are calling us for our pandemic cash distribution program and our food distribution or mass distributions on the ground is that their colleagues are dying, that family members are dying. There's a lot of need. And from what we're hearing on the ground, we know that there are farm workers who are under the ages of 65 who are high at risk, severely sick, or who have passed away. So the recent UCSF study that just came out very recently showed that what has been alarming us is now really it can be seen in data. So Latino food agricultural workers have a 59% increase of death compared to prior to the pandemic. So this survey really documents the urgent need to continue to prioritize farm workers. And this was data that was based on death certificates from the State Department of Public Health. So, in mid-December, we sent out a text message survey and over 14,000 farm workers responded. 78% said that they did not have any health insurance, and 13% of those respondents also said that they'd never been to a doctor for a regular checkup. And so you're thinking these are individuals who are in all indices of vulnerability, who are mainly immigrant, mostly Latino, who are low-wage earners, who are almost, over half are undocumented. You are really, I think we as a society need to look at the fact that these are individuals who are very much exposed, they're at high risk, and the status quo really isn't cutting it.
Thank you, Deanna, for really, I think, illustrating for us what's happening in the farm worker community, which we know, and you just sort of, I think, really perfectly sort of summarized, has been one of the most impacted communities throughout this pandemic for a number of reasons. So thank you for sharing that. And now I want to turn to Liz. And, as you heard in her bio, Liz has been working on the response every day and comes to us from a public health department. And our local public health departments have had such an important and challenging role. And so I want to ask Liz, and I'm going to ask Joel if you can throw up the slides for Liz. Liz has so many things she does that we really need to see it visually so that we can understand the scope of what public health does. And so can you tell us about the role of public health departments in this time and sort of what you've dealt with over the past year?
Absolutely. And again, I just want to thank you again for having me. It's really an honor to be here to talk to you about COVID-19 and how we have really utilized some of our best practices in public health and our best practices in health equity in order to battle this pandemic. And this pandemic, frankly, as the previous two speakers spoke about, has been devastating. It's been devastating to our region. It's been devastating to people of color, and here in San Diego County, particularly Latino population. Just to give you some context, over at San Diego County, our population is about 3.3 million. And of the 3.3 million, 33% are Latinos, 5% are African American, about 13% are Asian. And then when we look at our COVID data, next slide, please. When we look at our COVID data, we can see that our cases heavily, disproportionately impact our Latino population. While Latinos make up 33% of our population, they make up 56% of our COVID cases. And this, frankly, is unacceptable. And even worse, 44% of deaths in San Diego County. And so we lead here in San Diego County with data, and this informs our interventions, our practices, our engagement with the community, but we realize that that's only one data point, is our data. The other data point is really engaging with the community and hearing from the community specifically. And so we made a concerted effort and have contracted with 7 different community organizations that represent different populations of color, different communities, refugees, Latinos, African Americans, tribal nations, to really hear from them and as trusted messengers in the community. And we meet with them on a regular basis, and that entire process also informs our interventions as well. So your question to the role of public health in our response, if I can go to the next slide, please. Next slide. So typically, just public health in general, we are known for responding to disasters, to epidemics, pandemics. This is what we do. And frankly, this is kind of our Super Bowl. We've been practicing this for some time. Our systems are ready. And here we are. We lead in terms of San Diego County with our vision of Live Well San Diego, which has health equity components all ingrained in it. Really, it's building better health, living safely, and thriving for all San Diegans, whether you work here or live here. And from a public health perspective, our core public health practices of prevent, promote, protect. And then of course, we at a public health, even deeper level, lead with the 10 essential services of public health with equity ingrained through all of those components. So that's public health and at a very high level. Next slide. So during COVID, next slide, we continue the 3 Ps, prevent. Our goal is to prevent the spread of COVID-19, to promote non-pharmaceutical interventions, vaccines. We, again, want to focus on those who may be hesitant in accepting the vaccine, slow to yes. And so we continue to reach out to those communities, utilize our trusted messengers that we have contracts with, and do continuing messages in different languages so that we're able to get the word out and be informed. And lastly, protect the lives and livelihoods, because we all recognize that there is an economic impact to this as well, all through a health equity lens. Next slide. So Kieran, I'm not sure if you're going to talk about why we've moved towards equity, or am I jumping the questions here?
Yeah, no, that
So
was that. I think that was a very helpful, I think, overview of public health and the role of public health, Liz. And we're going to come back to you in a minute. So Joel, you can pop the slides down just for a second. Thank you. So I want to go back to Deanna for a minute. And, you know, you've really been very vocal with the state. You've been in the media talking about vaccines and the need to prioritize farm workers. And the state, it's kind of dizzying the number of different directions the state has gone in at this point. But I want to ask you, both, you know, explain to us the need to have this explicit prioritization for farm workers, and tell us, you know, how, like, beyond the prioritization and the eligibility, how are you advocating that be done? And then it's a 3-part question, so hang with me. And then what are you seeing today in terms of vaccine rollout? Because as I understand it, farm workers are supposed to be eligible now, right? But what are you seeing and what are you recommending?
Yes, well, we've certainly advocated to have farm workers prioritized and have been successful in having the state include farm workers, agricultural workers in phase 1B tier 1. However, what we're seeing is that farm workers haven't necessarily been prioritized on the ground. So at this point, it really is just on paper. So it's very disturbing that many counties are not yet prioritizing agricultural workers. So far as we know, it's only been a few counties that have done so at this point. And, you know, given the data that I just mentioned regarding the UCSF study and what we're hearing anecdotally from farm workers on the ground, it's really something that we need to address as the state is now mobilizing to a more centralized system and not as focused at the local level. But, you know, what we're trying to inculcate is the fact that we need to prioritize a very specific, intentional, mobile vaccination strategy that reaches farm workers where they're at, whether it's at the workplace or in the rural communities where they live, during the hours that they are not at work. Many of the vaccination sites that we've noticed are happening during work hours. For instance, many farm workers work 5 to 6 days a week, Sunday events, the types of considerations for the logistics of events that are being conducted on the ground need to be taken into account. And so a multifaceted strategy really needs to be in collaboration with the community-based organizations that work specifically with farm workers, such as the United Farm Workers, the UFW Foundation, other CBOs, and community health centers who've historically worked with uninsured constituents. What we're hearing, however, from community health centers is that they're not receiving very many vaccines. And so, for instance, one of the federally qualified community health centers in the Coachella Valley that's fairly new was provided with 50 vaccines for this week, 50. We've heard from San Benito County, the community health center there had 0 vaccines. And so it's really important that there be a transparent way to figure out how are vaccines being allocated and distributed on the ground. Many of the large hospitals that are receiving direct vaccine tend to have patients that are insured. And so we need to make sure that those safety net service providers, vaccinators on the ground are part of that integral system to ensure that the most vulnerable populations are reached and that they're reached through mobile vaccination. The process that we are also seeing through registration that's being employed is quite complex. Many farm workers have limited digital literacy, although they have phones. Navigating a website is challenging, and then being on the phone for 2 or 3 hours to try to get an appointment is also challenging when they're working long hours. And so it's really important to make that registration process easy for farm workers and other vulnerable populations to be able to get vaccinated. So for example, in Coachella this week, tomorrow we're going to hold a vaccination event, and the UFW Foundation identified the farm workers. We called them directly. We provided them with the information. All we needed was their name, their phone number, and when they get there, we provided a span of time when they could get there after work. That it was really important that farm workers understood, no, ICE isn't going to be there. You don't need to be documented. That information is not going to be asked. And so I think it's really important that both at the local level and at the state level, that the governor, that public health officials like Dr. Hernandez, that you all are also providing that information, that those who are undocumented have to be part of this process, that this is also something that is accessible to them. So there are a lot of different components here that need to come together to ensure that we quickly are able to make these systems much more accessible than they currently are.
Thank you, Deanna, and your advocacy on this has just been tremendous, and I think shown in getting farm workers back into the prioritization, right? So thank you for your advocacy. Liz, let's go back to you and picking up on some of the things that Deanna talked about. Can you tell us, how is San Diego County working to embed equity in the vaccine rollout? And even more broadly, how have you as a county department really focused your response on equity? And Joel, we can throw Liz's slides back up for this part.
Thank you so much. Deanna, you bring up some wonderful points. In San Diego, we've been laser focused in addressing those type of points. When we think about the beginning part of this response, we were doing a lot of contact case investigation, contact tracing, and realized that we need to do some work to ensure that our workers reflected the diversity of the community. And we made an effort to, again, contract with the community, engage promotoras, train promotoras in becoming tracers, and being able to engage at that level as well. And we use that same model as we transition into the vaccination phase. We know that there is a language barrier. We know that there's a digital divide with this population. So what we've done, again, using our trusted messengers, our community groups, our promotoras, we've trained them to go out into the community and really sign these individuals up for our vaccination stations. And not only do they sign them up, but we have reserved times at our super stations that no one else can access except these community groups. So that is something that we do 7 days a week, 7 a.m. to 7 p.m. to ensure equitable access from a vaccination perspective. Unfortunately, things that you're experiencing across the state is there is a vaccine shortage. That's just the reality. And we also are aligned with the state in ensuring that we follow the phase process. Because of the vaccine shortage, we here in San Diego are only vaccinating phase 1A, which are healthcare workers and 65 plus. because of the vaccine shortage, we have not had a chance to go beyond the 65 plus into phase 1B, tier 1, which is more of the law enforcement, the teachers, childcare workers, and food and agricultural population there. That's something that all of us across the state are facing. We look forward to, when we get more vaccine, to again continuing to open up the gates to ensure that all of the individuals that have been disproportionately impacted by COVID-19 be vaccinated in a timely manner. And so we'll go to my next slide, please. From a health equity perspective, next slide. Looks like some of the animation was a little, keep going. So this slide just kind of shows that in public health, you know, COVID-19 just didn't allow us to practice our health equity efforts. We've been doing this for the past 20 years, since 2001. And more recently, earlier this year, I'm very proud to share that our county has declared racism as a public health crisis, like many other jurisdictions across the state. And so just wanted to share and kind of frame the conversation from that perspective. Next slide. So our COVID-19 approach, again, always leading with health equity, started with prevention through collaboration. We cannot do this work alone. We need our community partners. We need our frontline employees. We need our business partners. We need everyone to be collectively on the same page so that we can move forward. And of course, we went through the various COVID approaches of testing, tracing, treatment, isolation, and now the last and hopefully final leg of vaccination. Next slide. And here's a kind of an outline of our sector and subsectors. Our Liberal San Diego really provided this foundation of community engagement. We've always engaged our sectors of business, community-based organization, faith-based organization, other government entities, and our educational partners. And through COVID, we were able to further expand that to other community sectors and subsectors. And we actually hold on a weekly basis telebriefings with each of these sectors and the community so that they can be informed about COVID-19 and vice versa. We can hear from them as well. Next slide. In terms from a health equity perspective, we have immediate strategies, long-term strategies, and cross-cutting strategies. So our immediate strategies in order to stop the pandemic, to stop the virus, was through testing, contact tracing, isolation and treatment, and worker protections. And let me just kind of share really quick in terms of the isolation and treatments, our public health hotels, as we call them. We found that the majority of, early on, the majority of those who stayed at our hotels really weren't the individuals that needed them. It was really, we didn't see a lot of Latinos accessing this. And again, we engaged our trusted messengers to ensure that people know about this, because they actually didn't know about the hotel option. That if they were sick or they had someone who was sick in their home, that they could, for free, come to one of our hotels and get 3 meals a day and some health screening and any other type of support. And they can bring some of their family members. They're not just by themselves. Long-term strategies, we're focusing housing security and homelessness, schools and childcare, economic security, health and health policy, transportation, physical access mobility. We're going to them in terms of our homebound seniors. We actually have engaged our CAL FIRE experts and partners and other groups to actually go to the homes of homebound seniors and provide vaccines. Cross-cutting strategies, always focusing on data, communication, language access, and cultural competency. For those that don't have computers at home, not only do we have our trusted messengers to sign them up for vaccines, but they can also call 211. And 211 can also walk them through the process and do the appointment for them as well. And 211 also offers this in various languages. Community engagement, that was just a major key, and focusing also on the mental and emotional health. Yes, next slide. So at the beginning of this pandemic, our strategy was test, trace, and treat. all through an equity lens, accessible COVID-19 testing. We had over 60 testing sites all throughout the region. We even stationed one at the border. So when people came in and out, it didn't matter if you lived here, worked here, had papers or undocumented. If you wanted a test, you received a test. Trace, again, culturally competent disease investigation. We worked hard to ensure that our tracers reflected the community, specifically from a language perspective. And treat, again, noticing that we made very much an effort, and I'll show you some data at the end in terms of how we've engaged this population in our hotels as well. Next slide. So our test strategy, we had various areas of approaches. In terms of equitable COVID testing, we had drive-up sites, we had walk-up sites, no appointment testing sites, mobile testing sites. We had rapid response teams where we went out to the long-term care facilities, and Cal Fire and San Diego County Fire focused on more of the rural areas. And under the mantra of ACT, which is accessible COVID-19 testing, that was our mantra throughout this. We also had a very much, in looking at the data, we noticed that our South Bay community was hardest hit. Very similar to, I think, the speaker before, they said there's parts of Oakland. Our South Bay community was very hard hit. And we basically developed a South Bay saturation strategy. And we focused on Latino-focused testing. We went out to the Mexican consulate, set up a testing site there, churches, Latino markets, other sites, sites for farm workers as well. We've engaged our tribal communities and ensured that there's testing sites there as well. They've been harder hit as well. So we've really tried to ensure that wherever we saw a surge in cases, we saturated that with support and interventions. Next slide. So here we have our phases of the vaccine, again, just from an equity perspective. Next slide. Throughout the state of California, the governor, you may be aware of the Healthy Places Index. He really utilized the Healthy Places Index to ensure that we as an entire state are focused on those that have the least healthy communities. So those of you who may not be aware of the Healthy Places Index, it's basically, there are four, basically when a region is categorized into four groups, the healthiest communities down to the least healthy communities. And it's based on those 5 areas that you see there. And every census tract receives a score. Next slide. So what it looks like is you start creating what we call HPI quartiles, where the healthiest communities are in green and the least healthiest communities are in dark blue on this graph. And you can see those black dots. Those were all of our testing sites or testing accessibilities where we ensured that our testing sites really overlapped with the majority of the blue areas for accessibility. Next slide. And here we are from a vaccination perspective, same approach. Here in this slide, instead of the dark blue, it's the hash lines there are what we call the least healthy communities, or we call it the health equity quartile. And we ensured that our vaccine locations and our super stations are either right on top of those HPI health equity quartiles or very, very close next to it. And then of course we partner, we can't do this alone, with our vaccination providers and our community groups, including our federal qualified health clinics. Next slide. So in terms of following the investment, following the money, following our efforts, we look at our health equity quartile. So again, this is the areas where there's least amount of healthy conditions in terms of income, in terms of schools, education, employment, whatnot. And we looked at where is the money landing? And the goal is definitely to have at least a 25%. And as you can see, from right to left, our public health rooms, more than 50% were those that actually lived in the health equity quartile. We had stipend payments for those who unfortunately did come down with COVID-19, and we gave them $1,000 a week so that they can stay at home and not have to worry about income. And you can see those who lived in the health equity quartile were the majority of those that actually access this program. And same thing with emergency rental assistance and so on. Next slide. And as you probably can tell, we're very much a data-focused organization and county. And so all of our data by race and ethnicity is posted on our website for anyone to see and provide feedback. Next slide. We also, from a report perspective, we have what is called a County of San Diego COVID-19 response plan. And in that response plan, there's 3 components: our testing strategy, our health equity strategy, which you see here, as well as our vaccination strategy. Next slide. And our health equity strategy, as you can see, is composed of 5 various strategies: finding evidence-based for COVID-19 health equity data, expanding county program services, protecting essential frontline workers, expanding an inclusive workforce, and collaborating with community partners. Next slide. I'll pause there.
Great. Thank you for that really robust overview of all of the efforts in San Diego. I know when we looked at some of the recent just general data about vaccines, it seems like it has been getting out in San Diego, at least a little bit more than in some other places. So it's helpful to understand what's behind that. I really want to bring Noha into the conversation because one of the things that I know we always point to at CPEN is sort of the model work that's happening at Roots Community Clinic, both around the community testing being one of the first places to open up as a walk-up testing site, and thinking about the role in vaccine distribution. So Noha, can you tell us a little bit about what you've done in terms of community testing that's maybe different than what's happening in a lot of the rest of the state, and how you see that moving into vaccine distribution for your community?
Sure, thank you. Yeah, so we were the first walk-up site in the East Bay, and we really designed it to be very low barrier, super easy to register. We have people who, may live in an encampment and can just get on their phone and register for testing and have been accessing our testing site that way. But it's really, open to anyone in the community. And we, designed it that way from the outset because we understood the barriers within our community about, having to go through multiple steps where you're having to maybe consent to, your information being shared, or even your genetic material perhaps being shared, or kind of vague disclaimers and disclosures that we've seen on a lot of the different platforms that were coming out at that time. And we sort of, as we went through those, we said, okay, this is going to be a non-starter. We're going to lose a lot of our community if some of these things are built in. Also, certainly the walk-up style was really because at Roots, people, from the community are always kind of walking there and being there because it's, an anchor in the community where people feel comfortable and where they trust. And so we wanted to make sure that we created that easy access, and especially for obviously people who don't have a car, we wanted to be able to really create that access. And just having people, our staff completely reflect the community that we serve. Our patient population, as well as our staff, are about 85% African-American and about 10-12% Latino. So we really, and that's our patients, that's our community. With the testing site, of course, with the demand and the real burden of cases in the Latino community, a lot of that has shifted, and we definitely scaled up in order to meet that need. But one of the persistent concerns is that in the African-American community, even though our case rate is not as high, the death rate is about double. in our county and in a number of places across the country. So people are dying at double to triple the rate. People of African descent are dying at double to triple the rate when they get it. And so we are just as concerned about that disparity and wanting to make sure that the community understands, like, just because we're not maybe getting hit as hard with cases, the risk of your dying or doing very poorly from it is a lot higher. And we don't really know all of the reasons why. And that's something that we're really pursuing and investigating heavily. But within that is that messaging that you still have to be just as vigilant. And I think the other piece is that the information that we've collected at the testing site has really, we've done it in an effort to understand better what's going on and be able to reflect that back to the community. And it's very different based on, again, the neighborhood and also even race, ethnicity. So what we've seen, even just comparing with Latino and African-American communities, is that the number one likely source has been the workplace for both groups. But then when you get down into the second cause within our Latino community, it's more household spread. So within the household with multi-generational spread, and that obviously has its own concerns with more vulnerable people being in the home with essential workers. Also, as I think Diana had mentioned about carpooling and those kind of things that we're seeing a lot more in our data. In the African-American community, it's with a family member outside the household spread is the next cause. And so although there may not be as many intergenerational households, folks are checking on mom and going to auntie's house and doing, and that's where the spread is occurring. So our messaging actually has to be a little bit different. And we are noticing the same thing now, I would say, with vaccines, is that the messaging is going to be a little bit different. We're getting a lot more questions from our Latino brothers and sisters about, well, I had COVID already, so I don't think I need to get the vaccine. So that's a different education point than maybe within the African-American community saying, well, I haven't really been impacted by it at all. I'm not worried about it, right? Those are sort of like two different, or, you know, some of the, I think, questions and concerns that come up around the speed, you know, of how quickly it was and the mistrust that folks have. And some of the marketing that has unfortunately, I think, gone on and backfired a little bit of trying to convince African Americans to get the vaccine. And so we're having to overcome that, unfortunately. And so that's a different, a different set of barriers and concerns that we're needing to address. So all of this to say that I think a lot of the data has to be nuanced in order for us to give a nuanced response back to the community. And I love the use of trusted messengers that Liz was talking about. I think that's so critical and something that we're really finding that we're going to really have to lift up in all of our communities of color, and finding those trusted messengers within that community to really deliver information. And so I think one of the lessons that I think we learned in terms of testing, and just one of the things that I think is happening in this pandemic, is it's an overwhelming volume that we're dealing with, right? No public health department was ready for this volume, no clinic, no hospital, no country, right? Of the sheer just number of cases and the amount of infrastructure that has needed to be built just to attempt to meet the volume. And so there's a desire for scale, which is important. And so we've seen massive sites opening up for testing, for example. And we understand that that is going to meet some of the needs we have around scale. And certainly with testing, we want I wish everyone could just have a testing machine in their home, right? We should all have access to testing until we eradicate this thing. And so I think the desire for scale is important, and I honor that and understand that. And I will say that putting that massive site in a zip code, let's say, that is, you know, maybe is a testing desert or has some of those unhealthy indicators and so forth, is not the same as equity, right? It may be, but it may not be, right? So if you put a massive drive-up site in East Oakland, then our experience was in the earlier days with the pandemic, when some of these sites opened up, is that people from other communities were coming in. They were savvy at using the computer platform. They didn't mind all the disclosures and all the release of information that they had to agree to. They got savvy at getting their appointment times when there was waiting lists. They would keep trying and get in. And so we saw that other communities were coming in to take advantage of a resource that was intended for the place that it was situated. And so that is not only not equity, it's kind of the opposite of equity, because you're actually displacing the people in the community from that resource that was intended for them. And so I think we have to be super vigilant with this, and particularly when equity has become, you know, the thing to talk about and the thing to say. And I think we have to be really clear that just because you're putting a resource in a place, you actually could do more harm, especially if you're not taking effort to resource that community, right? So if you're actually paying a different vendor that will come for this and then leave, and you're not building up any capacity within that community, then that actually is kind of the opposite of equity. And so I know that's not what is intended, but those are some of the unintended consequences that we've seen even with the testing. And so we have just done a lot of work to say, this is how the interface is going to have to be in order for our community to access it. This is the kind of data capture and information we're going to need to be able to give our community back the information it needs to make the best decisions that it can. And with the vaccines, I think we've learned a lot, and we've seen that, yes, we can leverage all of that infrastructure in order to do vaccine delivery, but we have a lot of the same concerns about how equitable this is going to end up being, again, because I think of this tension around scale, right? We want everyone to get vaccinated. And so if our communities don't like hurry up and get vaccinated, we will be asked to give our vaccine supply to somewhere that will, right? And we're already seeing in our county a very significant disproportionality in who is uptaking the vaccine. Even if we only look at healthcare workers, we are seeing that it is not being taken up, particularly by African American and Latino healthcare workers who have much of the information. They have access to the information, they had early access to the vaccine, and are not choosing to uptake it right now. And what we're finding is that, and we're doing a lot of information sessions and really addressing people's questions and concerns, which are very legitimate, valid questions and concerns that need to be answered. And we need not shame people for not being ready. We need to acknowledge that this is a process and that we may not be the fastest ones, and it's completely understandable. That's exactly why Roots was created in the first place, because we knew that there was so much mistrust that the healthcare system has earned, particularly with people of color and particularly historically with African Americans, but contemporaneously with all communities of color, where you see what could be described as, I think in a best case scenario, helicopter research, right? We come in, we give you some gift cards, we take out the data goes somewhere else, we never get the benefit of the data. That in and of itself is problematic. And then some examples that are, more concerning around, lack of an attempt to have inclusivity in trials, device trials. We're seeing now that the pulse oximeter, the very device that is used to determine whether your oxygen levels should warrant your getting admitted to the hospital or getting taken to the hospital, it does not work as well on darker skin tones. This is kind of like a bombshell that we all need to be very concerned about and ask ourselves, how did this happen? How did this get through device trials when it doesn't work on darker skin tones? It's really mind-bending. And so I think that, to try to minimize it, by saying, oh, Tuskegee, that was a long time ago. No, we are talking about a number of examples of how the healthcare system has earned mistrust, and our job is basically to overcome that. And so it is not going to be about parading around an African-American person getting the vaccine on TV and saying, look, you should get it. And I think that has been part of a mistake. And frankly, in my opinion, that seems to be backfiring in the community, where people are saying, why are they so worried about me all of a sudden? Why do they want us to get this vaccine all of a sudden? They didn't care before, right? And that is very legitimate. And again, something we have to work harder to overcome, to basically say, we need to share this is what we know, this is what we don't know, this is the decision that you have before you. And that process is going to take longer in our communities. And so what I don't want to see happen, and which unfortunately I'm already seeing indications that it is happening, is that, well, we tried to do this over here, they didn't want it, so we had to take it over there, right? And we're also already sort of getting signals that say, well, we really need to go to, places that can handle this amount, this many doses, and it's like, look, we have freezers. The freezers are in the community. And if you're worried that the communities don't have freezers, how about we invest in the infrastructure, the equipment, the supplies, the staffing, so that in the recovery phase, we are better off than, we are left better off than we were when we started. My biggest concern, and what I'm seeing sort of repeating itself, is sort of, and now it's kind of worse because it's in the name of equity, is that, again, we're going to helicopter in, we're going to, do this response, but really the people who are getting the contracts and so forth are corporations, not the communities. And then when they're gone, they're gone. And I will tell you that for our community, when some of those sites popped up, it's like, I don't know these people. I don't know where to find them when this is over. I'd rather come to my community health center where I know the people. If I didn't get that text message or that email, I will just show up and ask for my, result or whatever. And it's going to be the same thing with the vaccines. There's going to be a much harder time engendering that trust when you have sort of I don't want to call it a fly-by-night operation. That's not the word I want, but you have something that pops up out of a need. And I do not want to downplay or minimize this need. We need scale. There's no question about it. A site that could do 5,000 vaccines a day, bring it, please. We need to get that done. But just as important, we have to preserve and protect our supply or our resource for our community that needs it. And if it's going to take a little longer to get us there, then we need that grace. But guess what? Someone needs to ask us that question, right? Is it going to take you a little longer? Okay, no problem. That's the conversation we need to be having. Not if you can't deliver on this, we're going to shift this over here. And I think that is the biggest concern, because as we've seen with testing, because adequate access was not created across the board at our large systems, at our private hospitals, our private settings, that a lot of the folks who have insurance are accessing community sites that were really designed for a community. And I think when it came to testing, a lot of us felt like it's fine. We can absorb Roots felt it's fine. We have people in our community that have insurance, and if they cannot get into wherever that is that they go, please come, because we want to stop the spread of this thing and we deserve to know. So we made sure we had enough access for everybody. Now, if we started to get to a point where we couldn't do it, then we have a different question, because equity would demand that we center the people most likely to be marginalized and don't allow that to happen. And unfortunately, that's just not the way these things typically play out. When it comes to vaccine, I think we're in a different situation. And I think it is a lot more important that we actually earmark, preserve access and resource for our community, because if not, in this situation of scarcity, we will get left behind. And the last thing I'll say is that what we're concerned about is that, there's a lot of parallels for a lot of us with HIV, with the HIV epidemic and with AIDS. And what has happened with HIV and AIDS is that at first we thought, okay, this isn't really affecting our communities of color that much, right? Then now, fast forward to now, is our communities that are dying. Everyone else has moved on. We've controlled it, right? We've got treatment, we've controlled it, we've got testing, and in some communities, it is absolutely controlled. Our communities are disproportionately dying. And so what we worry about is a repeat of that kind of a scenario where our communities are still ending up with cases, are still ending up dying, and are still perhaps even suffering from, what we're saying now is long COVID. We have no idea how long COVID is. And so will we be ending up with people with chronic lung conditions, chronic cardiovascular conditions from this? We just simply don't know. But I worry that it is our communities that will bear the burden of this long after we think it's controlled overall.
Thank you so much, Dr. Noha. I think those are very sort of poignant and powerful considerations for us all as we sort of think about where we're going from here and what comes immediately next, right? And so just to close, I want to ask each of you sort of a lightning round here. When a lot of people are sort of talking about what we want our communities, what we want our state to look like, right, when we emerge somehow, someday, right, from this pandemic. And so I want to ask you, when you think about this new normal or this more equitable normal, if you could tell us just in one sentence, what do you wish for? And maybe we could start with Deanna.
In one sentence, I would certainly say that we want to ensure that farm worker vaccine allocation is preserved for farm workers, that it's distributed equitably, and that those organizations that are working specifically with farm workers are engaged in the process. And just in a little another sentence is just the fact that we really, really need to ensure that at a policy level, we need to address the issue of paid sick leave and the fact that many low-wage workers are making very tough decisions because they're counting the pennies, they're living paycheck to paycheck. And so to make a hard decision to stay home if they're feeling ill from COVID, or if they've received the vaccine and they're not feeling well for a day or two, that is not a concern for them, that they're able to take that time off. We really need to look at this in a holistic way.
Thank you, Deanna. Absolutely agree with that. And Liz, what's your one sentence wish for the future?
So my one sentence would be, if I could wave that wand, our focus on addressing the crisis within the crisis. So with COVID-19, that's a crisis, but within that, the larger crisis is our structural inequities, right? A couple of years ago, we had hepatitis A. That was a huge crisis, but underlying that was a homeless issue and a housing issue, income issue, fires that are just out of control. What's the underlying pinning there? Climate change, really addressing the crisis within the crisis.
That's powerful. Thank you so much, Liz. And Dr. Noha, can you give us sort of the final sentence about what you wish for the future?
I'll try to get it in one sentence. So yeah, I think my wish is that we truly uphold what the real meaning of equity is, rather than maybe hiring someone or checking a box with a new office, that we actually center the folks who have been most marginalized or are the most likely to be marginalized, which would include involving them in the design, the implementation, and the analysis of data of what is working and what is not working, and really allocating resources accordingly to those anchors within the community that can uplift that, and that we really honor community defined practices. And that looks different from community to community, but we honor them, we uplift them, and we resource them.
That's beautiful. Thank you so much for closing us out with that. I think that comes back to the equity is about power, right? And we really have to shift power in the society. So I want to give you all a huge virtual round of applause. Our deepest gratitude. You are incredibly generous with your wisdom and your expertise and the stories of your communities, and we don't take that for granted. And so really want to thank you for opening our conference and for sharing with us today. I'm going to hand it over to Monica to give just the logistical information about how people get to the next session. But thank you again, Liz, Deanna, and Noha for being with us today.